everyone. Welcome to DocTalks. I'm Dr. Manju George, the Scientific Director of Paltown Development Foundation, the nonprofit that supports Colontown. Today, we have two expert clinicians to tell us about Krukenberg tumors and colorectal cancer mets to the female reproductive tract. I'm turning it over to Dr. Xie. Could you please introduce yourself?
Yes, thank you for the invitation for the presentation. So my name is Hao Xie. I'm one of the GI medical oncologists at Mayo Clinic, Rochester. So my specialty, particularly focusing on the colorectal cancer and also early drug development.
Okay, thank you. Dr. Sood, could you please introduce yourself?
Hi, everyone. I'm Divya Sood. I'm a surgical oncologist at Oregon Health and Science University in Portland, Oregon. My focus is primarily in GI cancers, but also in peritoneal surface malignancies and oligometastatic cancers as well.
Okay. Thank you for joining us. Dr. Xie, you can continue with your presentation. So how we will do this is first Dr. Xie will speak, and then there will be a gap for questions, and then we'll hear from Dr. Sood. And then towards the end, we can take, both of them will take our questions. So as you hear the talk, when you have questions, please type them in chat. Okay, thank you.
Okay, sounds good. So I'll get started. Since I'm a medical oncologist, mainly I'm just gonna talk a little bit about what is Krukenberg tumor epidemiology, general treatment principles from medical oncology perspective. So first, people may ask, what is the incidence of ovarian metastasis from colorectal cancer? Because there are a lot of different GI cancers, such as colorectal cancer, gastric cancer. Occasionally, we see pancreas cancer can spread to the ovaries or the other female organs. Occasionally, we also see this from the lung cancer, breast cancer. But one important question is, how is this different from primary ovarian cancer? So first, the incidence of the colorectal cancer ovarian metastasis is not common, but it's about 4.6%. Different studies in the past reported different incidences. Really depends on the patient selection. So from this so-called kind of summative meta-analysis basically demonstrated the incidence is about 5%. Not a lot, but we see many in tertiary medical centers. So the next thing really is to talk about what are those histologic subtypes of colorectal cancer or ovarian metastasis. Again, colorectal cancer is a type of cancer called adenocarcinoma. Out of those, you could have mucinous adenocarcinoma, could have signal ring type, but all those terms are really defined by how those cancer cells look like under the microscope. And rarely you could see mixed adeno and the neuroendocrine tumor. So based on the different pathology, and most of the cancers are really the typical type what we see is adenocarcinoma. And it could either be wild differentiated, means that when you look at the cancer cell under the microscope, they look more like a normal colon mucosa or the lining of the colon, or it could look very differently from the colon mucosa. That's why we say poorly differentiated. Also, nowadays we talk about the management of colon cancer in terms of the location. Either they are in the left side of the colon rectum or the right side of the colon. Prognosis are very different. So in terms of the Krukenberg tumor from colorectal cancer, a lot of those are involved by the cancer from the left side of the colon, as you can see, about 50% versus the other parts of the colon. And then nowadays, next generation sequencing has become the standard of practice for patients with stage 4 colorectal cancer. We usually do next generation sequencing upfront when we see patient with newly diagnosed disease. This is a nice study from Memorial Sloan Kettering Cancer Center where they look at their patients, matched primary colon cancer, ovarian metastasis, and metastatic disease from other sites. Then they sequence the tumor for different molecular alterations as shown here. Those things represent different genes. As you can see, in general, primary colon cancer has a similar genetic alteration profile compared to metastatic colorectal cancer. However, in some cases, there are some small differences between the primary colorectal cancer and ovarian metastasis. Just to take common genes into consideration, we see TP53, APC loss, KRAS mutations, SMAD4 pathway alteration in colon cancer all the time. When you compare the patients with ovarian metastasis versus a patient without it, you can see there are some differences here in terms of more KRAS mutations in ovarian metastasis versus less or fewer patients without ovarian metastasis, and also the SMAD4 alterations are more in patients with ovarian metastasis. Other things to consider would be gene amplification. That's one type of the molecular alterations. Typically, people talk about mutations, but also gene amplification, specifically HER2 amplification, is targetable nowadays, such as those that we see in gastric cancer, colon cancer, and breast cancer. As you can see here, for Krukenberg tumor from the gastric cancer or stomach cancer, certain gene amplifications are a little bit different between the primary cancer versus the ovarian metastasis, versus in colon cancer, you do not see much difference between the primary cancer, lymph node metastasis, and the ovarian metastasis. This is actually consistent with what we usually see in the literature, that molecular alterations are pretty much similar between the primary colon cancer and the other metastatic sites. The next thing I want to talk about is really try to answer the question I mentioned earlier, the difference between primary ovarian cancer and the Krukenberg tumor from other GI cancers. So typically, a patient could present with a newly diagnosed cancer, mainly with ovarian metastasis. Then we need to figure out, is this a primary ovarian cancer which is treated very differently from if this could be a ovarian metastasis from the stomach cancer, colorectal cancer, or other type of cancers. Again, the treatments are very different, so it's important to figure out the difference, especially if there is a occult primary in GI and the patient only presented with an ovarian mass. It is very important, again, to figure out the difference. A couple years ago, we did a small study, try to look at if we can identify any clinical, pathologic, or imaging parameters that can be used to predict or to distinguish the ovarian metastasis from the primary ovarian cancer. So basically, if you look at this table, the first row represents the report from the radiologist. So as you can see, the accuracy to distinguish these two entities is only 60% among the expert radiologists at Mayo Clinic. Then we try to use other clinical or biochemical factors, common things that we see, age, CA-125, which is a tumor marker for ovarian cancer, and the CEA, which is a common tumor marker for colorectal cancer and some other GI cancers. The accuracy to use these three factors as a model to predict or to actually distinguish ovarian metastasis from primary ovarian cancer is about 88%. And since nowadays people talk about AI or deep learning algorithm, at that time I used a neural network algorithm try to predict the two entities based on the CT scan images. And unfortunately, we only see accuracy about 63%, which is not statistically different from our radiologists, but is worse than just a simple 3 clinical parameters. Another important thing to consider is really the survival. Patient with a newly diagnosed colon cancer, ovarian metastasis, how do we manage patients? What are the survival difference? Again, this is only a univariate analysis, meaning we did not adjust for other clinical or pathologic factors, but as you can see, this is what we call the Kaplan-Meier curve. The x-axis represents how long patients live, meaning their survival, and the y-axis represents the percentage or the proportion of the patients who have disease under control. That's what we call the progression-free survival, versus overall survival, meaning the proportion of the patients who is alive at a certain time, if you look at the x-axis. And the curve represents, if you go along with time, you follow patients for a certain period of time, what is the proportion of the patients who still have the disease under control or who is still alive. So you can see here, if the patient receives surgery, meaning surgical resection of the ovarian metastasis up front, they seem to live longer compared to patients who only receive medical therapy, meaning chemotherapy, targeted therapy, or immunotherapy that as a medical oncologist we prescribe. If you look at overall survival, it seems patients who receive upfront surgery also live longer. But again, the caveat is that we did not adjust the other patient factors, such as patient who only present with ovarian metastasis, or patient also have other metastatic disease, for example, in the other parts of their abdomen, liver, or lung. So the survival obviously will be very different. The reason we didn't adjust was because we only had 99 patients, 98 patients. So it would overfit the model if we do that. But certainly, it does give us some suggestion that surgery plays a very important role in the management of this disease, and Dr. Sood will talk more later. So again, there's also an interesting study a number of years ago. People looked at if we treat the patients with chemotherapy, treat patients with ovarian metastasis with chemotherapy, what was the response to the chemotherapy? So as you can see here, for patients with ovarian metastasis, most of the patients, they either have new disease progression, or only a minority of them had a stable disease, versus metastatic disease outside of the ovaries, such as liver, lung metastasis. You do see a number of patients, they could respond to the therapy, which was consistent with what we know about patients how many patients who respond to FOLFOX or FOLFIRI or other type of chemotherapy we usually use for patients with stage 4 colon cancer. So which means that the ovarian metastases are particularly resistant to traditional or standard of care chemotherapy agents, at least with those things at that time. Lastly, I will just kind of show you an example how people manage patients with colorectal cancer, ovarian metastasis. As you can see on the picture on the left side on the top, this is a coronal view of a CT scan. So you can see this is the liver, this is the stomach. You see normal liver look like this. You see a little bit darker area. This is a tumor in the liver spread from the colon. And also you see this big tumor here that represents the ovarian metastasis. So basically a patient at that time was started on standard of care chemotherapy called Capox, plus another drug called bevacizumab, another name is Avastin. They also follow the tumor marker CEA as a marker for response. As you can see, initially patient responded to first-line chemotherapy. However, after a few months, actually pretty soon, it developed the resistance, specifically the resistance from the ovarian metastasis. As you can see, the image showing on the bottom left, the tumor gets bigger compared to before the treatment. That's when the patient had elevated CEA. So at that time, the patient was symptomatic from this ovarian tumor. So then the patient underwent a surgical resection with some improvement of the tumor marker. Keep in mind that when we remove the ovarian metastasis, we don't typically remove other metastatic cancers, for example, in the liver. That's why gradually the tumor marker will go up until later time. We have to start the second-line chemotherapy, such as FOLFIRI plus bevacizumab. That's when the other disease actually was very sensitive to the second-line chemotherapy, have disease control for quite a while. So that's the kind of an example of a patient or the patients with this condition as being seen in the clinic. So that's all. Thank you for your attention.
Thank you very much, Dr. Xie. There are some questions in chat. Maybe we can go through them.
Okay.
So the first question is, are there different results for those who are otherwise NED when they develop Krukenberg tumors?
Is there different results for those who are otherwise NED when they develop? I mean, so the in the patients with colon cancer, it's actually interesting. For some of the metastatic sites, for example, oligometastatic disease in the liver, or if patient only has ovarian cancer, after surgical resection, they could stay what we call the NED, no radiographic evidence of disease, for quite a long time. But a lot of this is really related to the disease biology. You know, if that cancer has BRAF mutation, has KRAS mutation, the duration of progression-free survival will be shorter compared to some other type of or subtype of colon cancer.
Okay. Thank
yeah.
you. The next question is there any data about ctDNA and ovarian metastasis? And is CEA typically raised with ovarian mets?
To answer the first question, the ctDNA, there is no high-quality randomized study to demonstrate the utility of using circulating tumor DNA in patients with stage 4 cancer. However, I do order either the typical kind of the commercially available ctDNA testing after surgical resection of the ovarian metastasis or the oligometastatic disease in the liver. And if the ctDNA, 2 of them in a row are negative, then the chance that the patient will be in remission for a long time is much higher. So similar to, you know, like early stage colon cancer after resection. But based on at least our experience, we rarely so-called cure patients with ovarian or oligometastatic disease to the ovary. But again, it could be just because we don't see that many patients compared to oligometastatic disease in the liver, which we do cure some of them. The CEA depends on if the tumor is producing the CEA. So a proportion of the colon cancer does not produce CEA to start with. So then those ovarian metastases will not be able to produce CEA.
Okay, thank you very much. So Amber has this comment saying that she's very thankful that for her, during emergency surgery, the ovarian met was removed. So that's great to hear. The next question is there any connection to the age and ovarian mets?
From our study, the small study again, if a patient presents with ovarian metastasis at a younger age, again, it tend to be a GI, it tend to be a GI primary versus the primary ovarian cancer. But again, there's no large theory really kind of demonstrate the relationship. But again, when we see patients at different age, again, we practice the same. We have to figure out, is this ovarian metastasis, is this primary ovarian cancer, regardless of patient's age or other factors, because it's important to know which one is which.
Okay. And related to that, so are ovarian mets more commonly seen in colorectal cancer patients who are younger? Do you see something like that?
That's a great question. That's about early onset colorectal cancer. Again, based on the literature and my experience, it's actually it's now higher than patients who are older. We see both. Actually, the patient I have seen, based on my experience, are typically a little bit older. But again, a lot of factor contributes to it. For example, if patient has a high disease burden, they tend to have the ovarian metastasis. If patient has peritoneal disease otherwise, they tend to have the ovarian metastasis. So it's hard to definitively say.
Okay, thank you very much. The next question, if someone has ovarian mets on one ovary, is it typically more likely that it'll spread to the other ovary?
So you could see patients with metastasis on only one ovary. You could also see bilaterally. So this is not from the spreading from one ovary to the other. It's more the mechanism how people get peritoneal disease. It's more like a dropping to the ovaries.
Okay, I think the next question the person asks is, so if a person has a met to one ovary and they're having the Krukenberg tumor removed, is it recommended that they remove both ovaries?
That would be a great question for Dr. Sood, I think.
Okay. Okay, next question. For women with peritoneal mets, how often does an ovarian met happen?
It's a tough question, though. The way to answer this is that if patients have peritoneal metastasis, they of course will have a higher risk of developing ovarian metastasis because the mechanism really is similar. For those without peritoneal metastasis, they could also have it. It's just not a higher risk because the mechanism of spreading is typically not there. So I would say it's a lot higher, yes.
Okay, thank you very much. So then we'll go with Dr. Sood's presentation, and at the end, if you have other questions, please post them in chat, and then we can look at them then. Okay, thank you very much, Dr. Xie.
Okay. All right. Well, thank you all for being here, and thank you, Dr. Xie, for that fantastic overview. I'm going to try to build on it a little bit. I don't have any disclosures here. Briefly, what we'll talk about are some sort of indications for surgery, why you might need surgery for a Krukenberg or a secondary tumor of the ovary, how we would go about doing surgery, what the options are for approaches to surgery, some other considerations when thinking about having surgery for an ovarian tumor, and what to think about, what to talk to your surgical team about. Generally, we touched a little bit on this, but we'll talk briefly about some sort of prognosis and long-term outcomes after having surgery And then we'll talk briefly also about the option of prophylactic surgery, which is sort of a newer concept that, that we're thinking about. So for indications for surgery, there are honestly a number of different reasons that you might have surgery for an ovarian tumor or an ovarian met. It may be something related to diagnosis. So in a patient who doesn't currently have a diagnosis of colon cancer or ovarian cancer or anything else, and they present for the first time with a large ovarian tumor. And as Dr. Xie had mentioned, you know, in the setting of an occult primary, meaning we don't see evidence of a primary tumor anywhere else, and this is really all that we see. Sometimes what's needed is surgery to remove the ovary to get that tissue and get the diagnosis. So that certainly may be the case for some patients. For others, it may be related to symptoms or what we call palliative intent surgery. So they have a diagnosis, maybe they're undergoing chemotherapy or other treatments, but they have, as you can see in this image, a rather large ovarian tumor that is causing fullness, pain, abdominal cramping, bloating. It could be that they, you know, can't eat as much because they eat a small amount and then they get super full. And so it's making it harder for them to go through the rest of their chemotherapy or other treatments. That could be a reason to take out this mass so that they can otherwise continue with treatment. Similarly, in the palliative intent, but not necessarily related to symptoms, but is kind of what Dr. Xie had mentioned, that, you know, these tumors tend to be less responsive to chemotherapy. And so maybe the patient is having a good response in the liver and to the rest of their peritoneal disease, but this just sits there. The CEA remains elevated. And so it's not going to provide sort of the therapeutic or curative intent, but removing this allows them to kind of get rid of this almost clone of disease that isn't responding to treatment. And then the next one would be more of a therapeutic or curative intent. This is for a pretty selective group of patients who fall under the category of saying, hey, if we take this out and we can easily remove all of the other disease, they've demonstrated what we call good biology, meaning the tumor is behaving well, responding to treatment in a stable, kind of robust fashion, then maybe they're a candidate for something like a cytoreduction, meaning removing all of the visible disease that we know is there, and sometimes augmenting that with intraperitoneal chemotherapy or other adjuncts. And then, like I mentioned, prophylactic surgery is something, prophylactic meaning, you know, don't currently have metastases on the ovaries, but are at risk for it. And whether that's something we should be kind of prophylactically removing the ovaries for this is something we'll talk more about a little bit later. So potential approaches for surgery. There are a few to consider. The most common is going to be an open surgery, meaning a larger incision on the abdomen to remove the ovary, one or both, sometimes with or without the uterus and cervix. And that's probably going to be the most common in this setting, partly because often they're of a large size, and to get this out, you need a large incision. Partly it's also related to the nature of the tumor, that, you know, if you have a benign tumor on the ovary or a cystic tumor, sometimes you can puncture it, suck out the fluid, make it small enough to pull through a smaller incision. When you're dealing with colon cancer, rectal cancer, or other kind of malignant tumors of the ovary, it's usually not a good idea to do that. And so we caution against the idea of doing this minimally invasively with a laparoscopy approach or a robotic approach, unless the tumor is already quite small, that it's going to be easy to pull it out through a small incision. Similarly, I kind of put a line through this one. You may have heard of some people talking about the idea of NOTES, or what we call natural orifice transluminal endoscopic surgery, meaning not making any new incisions on the abdomen or in the skin anywhere, but kind of doing this through the vagina, and pulling it out through a natural orifice in the body. And again, that's something that's really reserved for patients with benign disease. It's not something that I would strongly caution against that approach to it, just because of the risk of sort of spreading the cancer. Some of the other things to consider. So when having surgery on the reproductive organs, there's a number of sort of short and long-term things to consider. And they're things that really should be discussed with your surgical team and the rest of your oncology team. Often when undergoing an oophorectomy or removal of the ovary for a metastatic tumor, we touched on this briefly, but it's often advised to remove both of them because of the risk of it being present in both. So often there'll be kind of a dominant tumor on one of the ovaries, but we've found that more often than not, if we remove only one in some amount of time, we can't say exactly when, but the disease will show up in the other ovary. And like Dr. Xie mentioned, that's not that it's spread from one to the other, it's just the nature of how this cancer, how it got to the first ovary in the first place, it's going to get to the second one in the same way. And similarly, when we remove them, both of them, one of them often has a dominant tumor. The other one, often we find on pathology that there is some evidence of cancer there already, and it just hasn't grown into the full tumor. So often we do advise removing both of them when you go in for one. And when that happens, if the patient hasn't already gone through menopause, then they're going through what we call surgical menopause. And the symptoms associated with surgical menopause are similar and often the same symptoms that you experience going through menopause naturally, but can often be more noticeable and more acute in nature. And so there are things that can be done to sort of mitigate those symptoms. And so it's important to have that conversation with your surgical team beforehand so that you know what to expect. In addition, there are some cases in which it's appropriate to preserve one ovary. Despite that risk, it's kind of a discussion that you have with your surgeon about desire to preserve fertility, anticipated risks associated with going through menopause at a very young age, including bone density and heart disease and other things that are associated with it. And so in certain circumstances, that's something that can be considered and kind of weigh the risks and benefits of doing that. Excuse me. Similarly, the uterus is a discussion, whether or not to remove the uterus along with this. Most often, if we don't see disease or cancer on the uterus itself, then just removing the ovaries is safe when you're, and is not going to necessarily change the outcome related to cancer. If there is disease on the uterus and we're otherwise going for sort of what we call curative intent, meaning trying to remove all of the cancer that we can see, then it's often advisable to remove the uterus as well. But along with that comes some additional considerations regarding pelvic floor health, sexual function, bladder function, all of these other things that relate to having a hysterectomy and the other procedures that go along with that. So these decisions are something that, again, you want to have kind of a close discussion with your team about it. What makes the most sense for each patient can be different and variable. Oftentimes, if fertility preservation and family planning is important to that patient, then they'll want to engage the reproductive endocrinology team to have that discussion. You can engage even pelvic floor physical therapy before and after surgery to try to prepare for that, as well as sort of a urogynecology team to discuss options related to bladder function before and after surgery. So then when it comes to sort of prognosis and survival, I think Dr. Xie did a good job of going over this, and I just wanted to provide kind of one additional aspect related to patients with this condition and what things look like after surgery. We used to have a fairly nihilistic view of metastatic colorectal cancer that, particularly in patients with peritoneal disease and ovarian metastases, that there was a lot of kind of nihilism around it. And I think that's really starting to change quite a bit in patients who have ovarian metastases and peritoneal disease. If they are able to undergo a complete cytoreduction, meaning remove all of that disease, the ovarian met, as well as any other peritoneal disease that they may have, the median survival that we're seeing is getting up there into 40 to 60 months is kind of the range. So we're looking at several years there, which is a big improvement over what we've seen with, chemotherapy alone, or historically the numbers that we've seen. Similarly, we're looking at, even the option of long-term survival in a cohort of patients. And so with low burden of disease, so I put on here PCI less than 10, PCI being a peritoneal carcinomatosis index, which is essentially a calculation of how much disease there is within the abdomen, how much peritoneal disease we see and where it's located. And when it's low, less than 10, we see overall 10-year survival reaching up to 40%, which again is a big improvement over what we've seen with chemotherapy alone. And that applies, that PCI of 10 applies similarly to patients who have ovarian-only metastases, meaning they don't also have liver metastases or other things like that. That puts it into another category. But just as we're seeing really big improvements in patients with liver metastases, we're seeing big improvements in patients with peritoneal and ovarian metastases as well. One of the challenges that we have is that it's harder to study. Most of the data that we have is around patients who have liver metastases, and patients with peritoneal or ovarian disease tend to be kind of not in most of the big clinical trials because it's harder to track the disease on imaging and CT scans and things like that. So we don't have as much data around it yet, but we're getting there. And so kind of along with that, it's just a kind of a reminder that those who get a complete cytoreduction overall tend to have better outcomes. Chemotherapy, as we talked about, is generally less effective on these secondary tumors of the ovary, or these Krukenberg tumors. And so patients should, make sure to be asked to be referred to a surgeon early, so they can at least consider whether they are a candidate for that. Not everybody is, but for those who are, it's good to have that discussion as early as possible. And that long-term survival really is an appropriate goal that we should be looking at for these patients. I mentioned a couple of times that we were going to talk briefly about the idea of prophylactic surgery. And up until recently, there's really no data necessarily to support the practice of a prophylactic oophorectomy in this setting. Most of the time where that's used is in patients with high-risk genetic mutations. So, for example, a BRCA mutation that puts them at very high risk of having a primary ovarian cancer. But nothing of that nature has really been, demonstrated to be effective or useful in colon cancer. There was recently a clinical trial that was published just within the last month or so, which doesn't directly apply to the use of prophylactic oophorectomy, but it does include it and kind of opens the door to this practice. What this study is looking at is the use actually of prophylactic HIPEC, or intraperitoneal chemotherapy, for patients with locally advanced colon cancer. So they don't currently have stage 4 or metastatic disease or peritoneal disease, but they have a locally advanced primary tumor and possibly lymph nodes associated with that as well. And this group was, everybody in the study underwent a cytoreductive surgery, which included a bilateral oophorectomy for patients who were postmenopausal. And in addition to removal of all of their disease at the time of surgery. And then they were randomized to either receive HIPEC with that, the intraperitoneal chemotherapy, or to not. And then everybody went on to get systemic chemotherapy after surgery. And it did demonstrate their primary outcome was looking at the benefit of the addition of HIPEC or the intraperitoneal chemotherapy. And that demonstrated a positive result, meaning that there was a benefit to the use of HIPEC. And so they weren't looking at the difference between doing a prophylactic oophorectomy or not, but it sort of opens the door to say that perhaps that addition to our standard cytoreductions that we're doing are worthwhile or beneficial. And it's something that we should at least consider looking at in the future. So something to stay tuned for. Just kind of final thoughts on this is that, as we talked about, there are several potential indications for surgery for these secondary tumors of the ovary. The surgical approach typically is going to be an open operation, but it depends on the size of the tumor, the indication, as well as the patient themselves. And so that's important to talk to your surgical team about. These really should be comprehensive multidisciplinary approaches. And so patients should ask to meet with reproductive, endocrine, and infertility specialists, sexual health, urogynecology, psycho-oncology teams should all be part of the decision about whether to have surgery and how to prepare for it before and after. Long-term survival, like I mentioned, is a realistic goal, and it's still there's still a lot of improvements to be made, but a lot of improvements have been made. Early referral for consideration of surgery definitely improves outcomes. And then there are some kind of exciting areas in the pipeline that are coming down the road. That's all I have right now. So I'm happy to take questions if there are any.
Okay, thank you very much. I think there are a lot of questions in chat. Yeah, so Amber asks, can preventative removal of the other ovary be something that can be requested to the surgeon? Can be justified to insurance?
Yeah, that's a good question. And it's definitely something that should be requested, particularly if, going in for one, the other one is very commonly going to be removed at the same time. And insurance, I at least have never had a problem with it, have never had an insurance company deny approval for the bilateral operation, meaning both sides.
Okay, thank you. Tina asked this, ovarian mets clearly grow quickly and are very large. Do we know how often ovarian mets rupture? If so, what are the implications of that?
In my experience, I have not often seen ovarian metastases rupture. I've seen them get to the point that they are very, very large and often kind of compressing other things in the body, but can get quite large, but rarely do I see them actually rupture. If they do, either before surgery or at the time of surgery, the implications essentially are that it increases the potential spread of of peritoneal disease. I would say that in most of these patients, when they have ovarian metastases, even if they do not have visible peritoneal disease elsewhere in the abdomen, they often do have kind of microscopic peritoneal disease that was likely to grow at some point anyway, or at least has already been exposed to it. And so it's tough to say exactly whether the rupture of the ovarian met was necessarily going to change significantly the outcome. But in general, we try to avoid it during surgery if we can.
Okay, thank you very much. So say, for example, there was this patient who has a large met, and then for whatever reason it ruptured. So would you think that at that point, if the patient is considering HIPEC, CRS and HIPEC, maybe that would be a good time to get it done if they didn't have any other indications that they were having peritoneal mets, do you think?
Yeah, and that kind of falls under this category of kind of prophylactic HIPEC to some degree if we don't have gross or visible peritoneal disease, but we suspect them to be particularly high risk. And I certainly would recommend it if they were otherwise a candidate for it. If they didn't have, visceral or extraperitoneal metastases, then I think it likely would be indicated at that time.
Okay, thank you. Elsa asks, if HRT isn't done, what is the alternative? Who should that conversation be with?
That's a good question. So typically that's going to be a conversation that you have either with a gynecology team, gynecology oncology, about, the best way to manage the kind of menopause symptoms after undergoing bilateral oophorectomy. And, if hormone replacement therapy is not an option or is preferred, a lot of times there are really good complementary alternative medicine options that can help support patients through those symptoms.
Okay. And then for bone health or cardiovascular health, there may be other things that could be done.
Absolutely. Yeah, there are definitely other ways to support that.
Okay. So Liz asks, what is the overall survival for people with high PCI who are not eligible for surgery?
Everyone's a little bit different. I'm not sure that I have the exact number of median, overall survival right now off the top of my head. But typically, if they're not a candidate for surgery, it's partly dependent upon otherwise their response to systemic therapy. And if they are responding, if not, then survival does tend to decrease significantly. And you start to look at less than a year potentially of survival. Oftentimes at that point, when the PCI gets too high, then the risk becomes bowel obstructions, which limit the ability to get other treatments.
Okay. Dr. Sood, would you estimate peritoneal disease as being about 12% of stage 4 CRC? This is the only figure she has found.
In terms of that, of the total number of patients with stage 4 colorectal cancer, 12% of them having peritoneal disease. I think that's a reasonable estimate. I might even venture to say that it's higher than that and that it's probably undermeasured in the literature, just because we're not studying it as much as we could or should. But so I'd venture to say it's probably higher than 12%.
Okay, thank you. And the next question is, should mutational analysis be done on these tumors?
On the ovarian tumor, well, I think that speaks a little bit to what Dr. Xie was talking about, that, looking at the mutational analysis and comparing that to the primary tumor as well as to the other sites of metastases. So he might be better to speak to that and the utilization of the mutational analysis.
Dr. Xie, do you want to take that? Yeah.
Yeah, so we do the mutational analysis on at least on one of the some tumor specimen. Doesn't have to be ovarian metastasis, because in my talk I showed that there are not that much difference between the primary tumor, other metastatic disease versus the ovarian metastasis.
Okay, thank you. So the next question is what do you think is going on about why they're so resistant to chemotherapy?
Honestly, I don't know. I mean, it could be, part of that could be the anatomy, the blood supply, and also, like how drug get diffused into the cancer cells. The same thing applies to the peritoneal disease in general. Certainly has something to do with the genetic makeup and also expression of, for example, the drug effluxing transporter of the cancer cells. So those have been studied. Those could contribute to the resistance to chemo. Okay.
Dr. Sood, do you have anything to add to that?
No, I think that all makes sense, that it's a combination, probably like he was saying, of the genetic makeup, but also just the inability, similar to other peritoneal disease. There's sort of a barrier of systemic therapy to reach it, is the other component.
Okay. Yeah, Annie says, thank you for bringing up that these those with peritoneal mets are not often part of clinical trials, or that their results are broken down in sub-analysis. Yeah, for those who get ovarian mets long after initial diagnosis, is that data commonly captured? Or are we not tracking that type of data? So, Dr. Xie, maybe you can tell us about the registry that you were explaining before we started the call.
Oh, yeah, I mean, I don't quite understand this question. If I understand that correctly, is that we are now particular, I mean, at least in the clinical trial or other large data like registry, we are now particularly capturing the ovarian metastasis. But if I remember correctly, there were two papers in Lancet Oncology about 10 years ago. Actually, the authors look into the ARCADE, the database, which is a database of all the metastatic colon cancer clinical trials. That they look into the incidence of peritoneal disease. They did include ovarian metastasis, but again, a lot of studies are really focusing on the peritoneal metastatic disease in general.
Okay.
People don't really single the ovarian metastasis out in large clinical trials or data registry.
Okay. So it might be of value to actually have a registry, like, you were able to publish it because you had that at Mayo, right? So it'll be, yeah, so the reason I say this is that in Colin Town, we have, patients who are seen at all kinds of oncology, clinics. So we have people who go to tertiary cancer centers. We have those who go to NCI centers. And we also have people who go to community clinics. And, we can see the whole spectrum of it. So with patients who go to community clinics and you have this large tumor, which is not responding to chemo, then, they are, by the time they're offered a surgical resection of the Krukenberg tumor, that doesn't really commonly happen. And because of the disease burden outside of the ovaries, many patients don't get to that. But in some cases, once the Krukenberg tumor is removed, then, their overall response becomes better because that is the one that is showing the super high CEA levels, so maybe having a registry and having more information would be useful because then, the patients could take that information to their doctor and say, here's some data, maybe this is something that we should consider, so thank you very much for this, for presenting all these, giving us all these information, because I think that's the most important value of these kind of talks. Let's see if there are other questions. Yeah. So I don't think there are any questions. So I have one question. So could both of you go through a case of a patient who's say, for example, let's do oligometastatic disease, right? So you have this patient with stage 4 colon cancer who has a solitary met at the liver. And that patient had, liver resection and the primary tumor resection, and they had some post-operative cleanup chemo. And then 6 months later, they have this rapidly growing mass in the ovary. So how would you manage that,
Well, I think I would, sorry, did you want to go ahead, Dr. Xie?
Dr. Sood, I'll let you talk first.
I was just going to say that, part of it is certainly dependent upon the patient's tumor biology. Certainly, the fact that there was sort of a relatively short interval between the time that they completed their therapy and when new disease showed up. When you're looking at kind of less than a year, what we call disease-free interval, or the time between completing therapy when you're considered no evidence of disease and then the next thing shows up, that is less than a year, is a little bit of a higher risk situation. And that kind of guides the decision making a little bit. I would say that in some patients, if they demonstrate otherwise good biology, the first time that ovarian met shows up and you've restaged them and there's truly no other evidence of disease, I would usually recommend a laparoscopy to take a look inside the abdomen, see if there is any peritoneal disease that we're not accounting for on the imaging, and then make a decision about whether they should have the ovarian met removed or start some chemotherapy again. Another line similar or different to what they were receiving before, kind of in discussion with the medical oncology team.
Okay.
That's how I would start it.
Dr. Xie, do you have anything to add?
No, I totally agree. Yeah.
Okay, thank you. So then let's consider another patient. The patient has been diagnosed with a primary tumor in the colon and has lung mets and liver mets, and they got first-line chemotherapy with a biologic, and they had very good response. And then now, they're getting maintenance chemo, just CAPE with the biologic. And then a year down the road, they have this rapidly growing ovarian met. How would you manage that patient?
I would take it in a similar approach, actually. So you're saying the disease like develop while patient is receiving the maintenance chemo. Certainly, I would stop the maintenance chemo first, and then I would get a good restaging evaluation on the CT scan, PET, for example, to look at if there are any other metastatic sites other than the ovarian metastasis. So if there is no other metastatic sites, it's really a decision. Either you go, certainly I will consult our surgery team first, right? So, and then make a decision based on the multidisciplinary discussion. So, but ultimately it's either you do surgery first, followed by potentially kind of quasi-adjuvant chemotherapy based on, for example, ctDNA result, versus I give patient 4 cycles of the new line of chemotherapy, for example, in this case, FOLFIRI plus something, and then reevaluate, and then discuss if surgery is indicated in that situation. Yeah.
Dr. Sood, do you have anything to add?
I think the only other, decision point, or the thing that kind of factors into the decision making, is whether or not there are symptoms related to it. Certainly, if it's symptomatic, that may push you in one way or the other. But if it's not symptomatic, then it may be a good idea to kind of get some systemic therapy on board in order to prevent, in case it's a sort of a sentinel finding, meaning that we see the ovarian tumor and then there's something else growing, it'd be nice to kind of shut that down with some systemic therapy before putting a patient through surgery, which is has its own risks associated with it in terms of creating kind of a pro-inflammatory state in the body that gives cancer a chance to grow. So I think that would be the other decision point, is whether there are symptoms.
Okay. Thank you very much.
If I can say one more thing, just pop up in my mind. Another thing to think about is that, for patients who have to go through surgery, they have to be off chemotherapy for at least 4 weeks. At least here, our surgeon prefers that. If patient is on bevacizumab, it has to be 6 weeks before and after the surgery. So if let's say the disease biology is poor, then I always tell my patient, yes, you can do the surgery, but if the disease biology is poor, when you come back, we do the CT, we see new disease in other places, right? So then you have the surgery, especially if they are not symptomatic, you have the surgery for nothing, right? Typically. So the surgery, one is, like Dr. Sood said, either to try to cure the disease or try to help with the symptoms. So really have to seriously think about it, really based on the disease biology. We do have, tools that we can use to try to get an idea about it.
Okay. Thank you very much. I think Tina was asking this question, and maybe you can expand on it. If they don't tend to respond to chemo, then why treat with a new line of therapy? And I think Dr. Sood mentioned that is just to make sure that if there's underlying disease that you can't yet see, to keep that in check while you're recovering from surgery. Is that right?
Exactly. Yeah. Even if on imaging, all you can see is the ovarian tumor, that doesn't mean that there aren't microscopic points of disease that we can't see on imaging. And like Dr. Xie was saying, the last thing you want is for us to go do a big surgery, take out the ovarian met. Meanwhile, you're off chemotherapy, we've increased the inflammation in your body, and now that microscopic focus in your lung or your liver has a chance to grow. And if we can give the chemotherapy ahead of time to prevent those other sites from growing, then that gives us a better chance of having an effective surgery.
So this talk was requested by members in Town because there is not so much information about specifically Krukenberg tumors, and especially mets to the fallopian tubes, etc. So it's really nice that you're able to do this.
Yeah, no problem. Happy to.
Yeah. And that paper, your paper is also really good. Like I had not found, anything to share. So it was great that I found that paper.
Oh, okay, sure. I will also cite a couple papers in my slides, and those are, I think those are, especially the Sloan Kettering theory is very informative.
Okay.
It's get a good quality data on this type of cancer, metastasis. So
Okay.
not a lot out there.
How did you get interested in Krukenberg tumors?
Oh, basically, my specialty is colorectal cancer. And we see quite a lot of patients with ovarian metastasis. The paper I was working on was when I was a fellow in training at Mayo.
Okay.
So Dr. Jolene Hubbard, and also before that it was Dr. Axel Grossi, actually initiated a kind of small study looking into our patients at Mayo with the Krukenberg tumor. So of course, there are things change. So I took over, and then basically, initially we were looking for some molecular patterns. But then I kind of adapted the project a little bit to my own interest using, initially at that time was thinking about deep learning AI, a lot of people talking about it. So I just gave it a try.
Okay.
Yeah.
Okay.
I'm still seeing, patients with the Krukenberg tumor from colon cancer specifically, sometimes gastric cancer, but since I see more patients with colon cancer, collaborate with our surgeon at Mayo, to help patients with this type of condition.
Okay, thank you. Okay, thank you very much. It's like 1 minute past the time, and this was very informative. Thank you for the great talks and the great discussion.
Absolutely. Thank you so much for having us.
Thank you.
Thank you. Take care. Bye. Thank
Bye
you all
now.
for joining. Thanks for all the great questions. So the plan is for the recording to be posted in Collintown University, and then people can watch it like at their convenience. Okay, take care. Bye.